pop that on.
Okay.
And then when you're not speaking.
Good morning and welcome to today's meeting of the Health Committee. Members of the public may like to follow at London Assembly on Twitter and use the hashtag Assembly Health for this meeting. May I please remind participants to silence your devices. We don't want any interruptions during the meeting. And the main item on the agenda today is maternal health and care in London. However, we have a few short items of business for the committee first. First of all, can I ask our clerk, Diane Richards, to confirm any apologies for today's meeting?
Thank you, Chair. Apologies for absence have been received from Assemblymember Both and also from Assemblymember Dr. Sahota, for whom Assemblymember Duval will be substituting later in the meeting.
Thank you. And can we note the list of offices held by Assembly members? And can I also ask Assembly members if they have any disclosable pecuniary interests in any specific items listed on today's agenda? No? Thank you. Can we confirm the minutes of the meeting held on the 25th of May 2022? Agreed. And can we note the ongoing actions arising from our previous meetings? Thank you. Can we note the responses to our recent investigations as follows? The response from the Mayor to our Reducing Drug Deaths in London report, the responses from NHS England and Improvement for London Region and the Office for Health Improvements and Disparities to the committees Trans Health Matters, Improving Access to Healthcare for Trans and Gender Diverse Londoners report, and also the response from the Mayor regarding the impacts of COVID-19 on NHS waiting times and the workforce strategy. Thank you. That brings us to today's main item. I'd like to extend a warm welcome to all of our guests joining us virtually and on the panel today to discuss maternal health and care in London. We have with us today Dr. Tom Coffey, OB, who is the Mayoral Health Advisor. We have Tinuke Owe and Clotilde, who are the co-founders of 5 Times More, and Dr. Suzanne Taylor, the Executive Director, Trade Union for the Royal College of Midwives. And also joining us virtually, we have Joeli Brearley, the founder and director of Pregnant Then Screwed, Maria Booker, the Programs Director for Birthrights, and Dr. Marilena Korkodilos, the Deputy Director for Health Improvement and Workforce Development and Clinical Lead for the Revalidation Office at the Office for Health Improvement and Disparities. So before we start our discussion, it's also important to announce that we are launching a survey engaging with Londoners on this topic, inviting them to share their own experiences, particularly over the pandemic period, but to see what can be improved. And we hope that anyone watching our meeting today will take part, and that people today will make sure that it's spread through their networks as well to increase participation as well. Details will be available shortly on our website and social media channels. So I'd like to start off with the first series of formal questions for the committee. And firstly, these questions are to Dr. Tom Coffey. I know you have to leave earlier on in the meeting, so we'll make sure that we'll ask questions directly to you at the beginning. How would you characterise the Mayor's role with regards to maternal health care and maternity health concerns in London.
First of all, thank you for inviting me, and thank you for choosing this topic, which I think is very important and very important to most Londoners. So the Mayor of London does not have any formal commissioning responsibilities for maternity services. However, he's got a role which I would describe as, in some areas, he actively kind of manages projects, often he convenes, often he will shine a spotlight on services and also advocate for kind of Londoners. For maternity services, we are very concerned in London of the disparities. We know that black women in London are 4 times more likely to die in childbirth than white women. That low birth weight, which is a indicator very much of poor outcomes from labour, and low birth weights in London are 3.3% of births, which is much higher than the 2.9% for England. So we recognise this is an issue for London. So what Sadiq very much tries to do is say, how can I create an environment to make sure Londoners are as healthy as possible, to do the work which would mean that women who are getting pregnant, going to labour and delivering are as healthy as possible. Also, how can we make sure that young Londoners have a good start in life? And therefore, the programmes like Healthy Early Years, which does a work with the early year settings to try to make sure children are getting school ready, working on good mental health for Londoners, so making sure that women who are in childbirth, who are having their babies, are making sure I have got good mental health services around them. On a regular basis, we meet the NHS on a monthly basis. And of that, we meet the Director of Nursing, the Medical Director, the Chief Operating Officer, and the Chief Exec of the NHS in London. And what we are very keen to do is and often take the reports that you present, take the findings, and then advocate on behalf of Londoners to the NHS. Sadiq always says, my role with the NHS is to challenge, champion, and collaborate. This is an area we need to challenge. We recognise the NHS doesn't always produce the best outcomes that we would want for our Londoners. And so from the meeting today, what I'll be doing is taking all the information that is being discussed, waiting for your report to come out, and I'll be raising that with the NHS at a future meeting. A few weeks ago, we met with the Royal College of Nursing, because I think one part of the discussion today was about workforce. Now, I'm very much aware that the Royal College of Midwives and Royal College of Nursing are very different, but they both face very similar challenges. One figure which we learnt about was that the average working career of a nurse 25 years ago was 30 years. Now it's 8. The ability to retain nurses and midwives into the profession is very difficult. So we've got a London Health Board meeting next Wednesday, the 6th of July, whereby a key deep dive area is on workforce. So we'll be raising the issues with the NHS in London about what are they doing to address the attrition of our workforce in midwifery and in nursing. And again, this is the opportunity where Sadiq, as a convener of the London Health Board, can also make sure that the areas of importance to Londoners are raised. So again, that will be another forum where Sadiq will raise this issue with the NHS, particularly around nurses and midwives. We are very aware of the inequalities that we've discussed that are faced by many women in London who are becoming pregnant and the outcomes. And therefore, the inequality strategy is done deliberately to try to make sure we address income, London living wage, mental health, air quality, all the things which will improve the physical and mental well-being of Londoners. And so Sadiq, therefore, has that approach whereby he does work in certain projects, he advocates, he shines a spotlight, and he convenes. And that's his 4 key ways that he tries to improve the services in London on maternity services.
Thank you. Just wanted a point of clarification. You made reference to birth weight and that having an impact on outcomes. Did you mean in terms of longer term outcomes or did you mean in terms of survival rates?
So both survival and long-term outcomes. So the lower the birth weight, the poorer the outcome, both for neonatal deaths, that's death in the first 28 days, and outcomes thereafter. And so the low birth weight in London is 3.3%, and it's 2.9% for England of all births.
Thank you for that. A second question I have for you is, how will the Mayor's health inequality strategy and implementation plan help to address inequalities in maternal health outcomes?
So, and I think I touched on that a bit on my first answer, I hope. So if we look at the health inequality strategy, there's got about 5 or 6 key areas. And therefore, what Sadiq will be wanting to do is to make sure that the health inequality strategy is meant for all Londoners. And therefore, women who are becoming pregnant, going into labour and delivering, are a key element of this community. So therefore, let's say, for the example, for the healthy child area. So therefore, the work we're doing there is, number one, on ensuring we continue to healthy early years, to make sure families and children get a good input into the first couple of years of life. Secondly, on mental health. So as we try to move towards having 250,000 mental health and wellbeing champions in London, again, they will work with the community. That community includes women who are becoming pregnant. Thirdly, and probably the most important one in this area, is the London living wage. When you talk to colleagues about the impact on health and health inequalities, poverty is probably the key area, and low income. Making sure we move towards a London living wage city, I think, is vital. And women often get paid much less than men, and the poverty can have an adverse outcome on maternity services. And the example we've just seen recently is the London Ambulance Service, moving all its cleaners in-house and putting them all on the London living wage. Lower workers tend to be women, and that initiative will address poverty and improve outcomes. The other area is air quality, and that is an initiative we've had for a number of years. And we know that poor air quality has an impact on the health of children and the health of adults, especially their respiratory health. And therefore, improving the air quality in London will improve the well-being of both women who are becoming pregnant and their children. And then finally, about active travel. How do we get people to be more active? Because what we know is that the more active you are, the healthier you are. The healthier you are when you go into pregnancy and go into labour, the better the outcome. So having a healthy London workforce, having healthy Londoners will mean that they're more likely to have a healthy baby. And so therefore, I would hope each strand of the health inequality strategy and its implementation plan will make sure that the women who are going into pregnancy are as healthy as possible, both mentally and physically, and have good outcomes. And that their babies also benefit from that healthy early years strategy that I've mentioned. Finally, we are promoting breastfeeding as well. And so we're investing about 25k each year in breastfeeding to make the GLA City Hall breastfeeding friendly, but also working with others in the wider business in London to make sure that they are making it as breastfeeding possible as they can.
Thank you. I think a lot of what you've mentioned is sort of work the Mayor's doing and City Hall's doing around the whole population. Is there any ways in which you are specifically targeting pregnant women or parents at the point where they're thinking about family planning as well?
So not specifically, no, because when we looked at our health inequality strategy, it's very much an idea that rather than narrowing it down to small groups, the idea really was to kind of make sure, can we make all of London healthy? And therefore there isn't any specific target on maternity services, but what we obviously do, as I mentioned earlier, is make sure that when we are aware of these outcomes that we've discussed earlier, that we raise these with the NHS, and Sadiq being very much a champion of Londoners to say to the NHS, these outcomes are poor. And that's why, in your previous reports, often you make recommendations of what we can do to the NHS. We log those, and we very carefully make sure we raise these on your behalf with the NHS to hopefully address the issues that you've identified.
Again, how is the Healthy Early Years London programme supporting maternal health in particular, and what has it achieved so far in relation to maternal health?
So its main focus, as you will know, is on healthy early years, right? It's on preparing children to what we call school readiness, right? Be it exercise, be it weight, be it teeth, be it behaviour, and so it's very much focused on their children. And so it doesn't have a focus on maternal health. It has a focus very much on children's health. But I think one would hope that every parent would want to make sure we maximise the improvements in their children's well-being, but there isn't a specific focus on maternal health in that programme.
Do you feel this could be an area for improvement?
I think it potentially could be something we would definitely consider, because as you can imagine, majority of people have more than one child, and therefore, as their first child goes into this program, and that mum might therefore become pregnant again. So it is an opportunity. It's a touch point whereby we've got young women coming into the program, and so it's something we could look at. At the moment, it is very much focused, I have to say, on children. But we will take your report, the lessons that you've learned, and see how we can address it accordingly. So it's definitely we will consider it, but at the moment that isn't its focus.
I'm going to turn to Assembly Member Russell.
Thank you, Chair, and good morning, everyone. And I'm afraid the first three questions I have are also for Dr. Coffey, and then we'll be moving on to our wider guests. So, Tom, how is the Healthy Place, Healthy Weight recovery mission supporting maternal health? Now, you've touched on it a bit, so if you've got anything extra you want to add on that.
So therefore, obviously, what it will work at is to try to have an impact on maternal weight as much as the weight of all Londoners. And so the school super zones are an area which is part of the healthy food, healthy weight programme. One area which London is doing better than the rest of the population is the maternal weight, and obesity of maternal weight when they go into pregnancy. And so the Londoner's maternal weight is lower than the rest of the country. And again, that is an indicator of poor outcome. So therefore, if you've got marked obesity in pregnancy and in labour, you can have poorer outcomes. So in fact, in that area, London is doing better than the rest of the country. And because we know that is a key parameter that will impact on the outcome of the pregnancy, both for the mum and for the child, that is obviously a key focus, because if we can make sure we keep maternal weights low when they become pregnant, that has a by far better outcome for both the mother and the child.
So do you think this is down to Londoners being more likely to travel actively, walk to the bus, catch the bus, do a bit more walking, kind of have more physical activity in our daily lives, or is it specifically the school super zones?
No. So to be honest, what I wouldn't want to do is claim credit where credit is not appropriately kind of identified. So I think it's a multiplicity of issues. I think so undoubtedly the more active you are, the better diet you have, the access to green spaces. All those things contribute. Definitely activity is one of the key drivers, and therefore, and that is why one of our other health and equality targets is to make people have active travel 20 minutes a day, for the majority of Londoners. So all those things contribute. I wouldn't want to claim credit to say that the Mayor's initiatives over the last 6 years is the reason why Londoners are less heavy than the rest of the country. It plays a part, but no more than that, I'd say.
Thank you. So now the Mayor has stated that the mental health and wellbeing mission is meant to support partners' work on resilience building for families and training for caregivers. What has the impact of this work been so far?
So therefore, at the moment, what we're very much measuring is people participating in all our projects. So therefore, our role is to promote Londoners to take part in activities which will improve the mental well-being of London. It's kind of very much led by Thrive, and it's asking people to take part in things like suicide prevention, mental health first aid, dementia friends work, the Community Champions Programme. So all what they're trying to do is to try to make sure that the community is resilient. I think for too long we've had very much a medical model whereby we wait for someone to become ill. When they become ill, we try to find, which NHS service can we refer them to? But during the pandemic, we realised when Sadiq convened kind of a mental health meeting of all the kind of mental health leaders in London, that what was more important is to kind of work on the mental well-being and resilience of all Londoners. So therefore, we don't wait till people become ill. And so therefore, the work of those 4 streams that I mentioned, of creating these mental wellbeing champions. At the moment, the target is 250,000. We're now at 85,000. And so we hope in the next 2 or 3 years, we will hit our target of 250,000 people going through those projects. And the reason I suppose it has a direct link to maternity services is that when we look at the maternal outcomes, the most common reason of death, for women is suicide in the postnatal period. So we make great efforts to make sure we control blood pressure. We talk about preeclampsia. We talk about kind of bleeding in pregnancy and hemorrhaging in pregnancy. But the most common cause of death in that 28-day period is suicide. So therefore, we've got to make sure that mental health for women, in preparation for pregnancy, during pregnancy, in the postnatal period, is a priority. And that's why I would argue that the work we're doing on mental health, so making sure everyone is resilient and improving mental health of all Londoners, is a key part of making sure maternal outcomes are improved.
Mm-hmm. Thank you. Well, certainly, I remember after my first child was born being totally overwhelmed by sort of hormonal sadness. So, and if you're in a situation where there's other things going on in your life, I can imagine that's a real risk factor. Now, 2 of the Mayor's Health Academy hubs explicitly reference midwifery as an area of focus. What objectives and targets have been put in place for midwifery training as part of the Mayor's funding for these hubs? And how will this be joined up with national funding for midwifery training?
Okay, so the hubs are very much ones which are focusing on non-university based training programs. To become a midwife, you have to do a degree, and as my colleagues, Suzanne will highlight.
I was
much more
going to
than
bring
I will,
Suzanne
right?
in next.
So therefore, so these are very specific and very professional training schemes. What the academies are trying to do is trying to get people into the healthcare professions to see, for school leavers, for Londoners who are unemployed, that healthcare and social care is a real industry that they should consider. And it's getting them in at the earliest step. So it will be on healthcare assistance. It will be on kind of those non-graduate training programs, working with FE colleges in their local area and the local hospitals to say, how do we get people into our hospitals to work? And then to go on an escalator program where people then go on to a university course at a later date. And some of the hospitals in London are trying to do that. Rather than just taking these 18-year-olds straight into a university program, they're trying to take local people who may not have 3 A-levels, which would get him at the moment into a midwifery course, which is quite competitive, but getting them into the first step of the healthcare program, and that's what the academies are focusing on. And then to move on thereafter, perhaps into a program whereby it's not the usual A-level entry scheme, but it's a non-A-level entry scheme into those programs. But the academies themselves won't be training midwives. Midwifery training, very specialised, based in universities, and usually overseen by Health Education England.
So it's about bringing in a diverse range of people into that first step, so that they can go on into midwifery training. I met with the Royal College of Nursing just yesterday, and they said, just in terms of increasing the work, the sort of lack of people in the workforce is a real problem across the whole of nursing and also in midwifery. So, they were saying that was a really useful intervention.
And one thing to add as well is the thing which I was surprised is, how do we get more and more people into midwifery and nursing? I'm trying not to step on your toes too much here, but in fact, the figures show now quite a lot of people are applying to do nursing and midwives. But the key issue now is how do we retain them? And in fact, the working conditions. When we met with the RCN, nurses going to food banks, nurses, kind of having to have welfare kind of officers in hospital to support their mental health and access to food shows, in fact, it's very hard to retain those nurses. So, in fact, I think the focus is probably going to move away from recruitment into retention.
Yeah, absolutely. And certainly we heard about, things like people who are doing home visits, kind of having fuel prepayment cards, things like that, where although you can claim back for fuel, if you don't have the money to pay for the fuel in the first place, then that's a real problem. Suzanne, do you want to come in at this point?
Thank you. And I was really interested about the work you're doing on encouraging greater diversity, because it is true that since the bursary scheme for nurses and midwifery was withdrawn, we've seen the average age of students coming into midwifery has decreased dramatically. So we no longer see older, more mature people who perhaps have already got one degree coming into midwifery because they absolutely can't afford to, because midwives now have to pay to train. And the apprenticeship model, where we have amazing maternity support workers who would like to go on to become midwives. The apprenticeship scheme is absolutely financially a disincentive for them. So things that do that are great, and I think it is really great that the London Mayor is investing in that. But Tom is absolutely right. Retention is the key issue. Both in our student cohorts, we lose around 20 to 25% of students, even though midwifery is a massively oversubscribed course, and we are losing midwives at a dramatic rate. And I know we were going to come into this a bit later, but I'll say it now, as Caroline, as you're leaving. Nationally, we've seen a decrease in the number of midwives employed in the NHS. By almost 2% in the last year. That's people actually working. But in London, it's 2.5%. So midwives are leaving. They're leaving London, and they're leaving the profession in London. And that is absolutely because pay. So the average midwife is now £7,000 a year worse off than she was 10 years ago. But all those other things you talked about the stress, the burnout, the fuel poverty. That I see maternity support workers who are leaving to go and work in coffee shops, probably because they can get their living wage. So retention is definitely the key.
Well, I heard from the RCN yesterday also that as staffing becomes tighter and as there are fewer and fewer people on shift, it's harder to give the level of care that you would normally give. So they talked about, in a nursing context, not being able to do sort of oral hygiene and really just having to focus on the basics in nursing. And if you're having those kind of pressures on you, then you can see that the stress of being at work just grows. And so it is more likely that people may leave.
I think it's a horrible toxic mix, because the fewer staff you have, the less able you are to give the kind of care that you want to give. If you're not able to give the kind of care you want to give, you become demoralised in your work and you're more likely to leave. So we're in a horrible toxic cycle at the moment.
Yeah, thank you. Chair, I'll hand back to you.
I'm just going to bring in Emma Best.
Thank you. Morning, everyone. Tom, there's been a 32% decrease in stillbirths in London since 2011 and 2021, but obviously that's of no comfort to those still going through this pain and those that are concerned for the future. What do you think, in your role, that you could advise the Mayor to do further?
So on stillbirths particularly, again, each one is a tragedy. because it's always late on in the pregnancy when everyone's making their plans, and then the tragic stillbirth is devastating for that whole family. And what we do know is that stillbirth is linked to certain areas. Number one, that you're more likely to get a stillbirth if you're got diabetes or overweight. Secondly, we know that stillbirths are higher in areas of poverty. And thirdly, that if your access to antenatal care is limited, there is a link there also to stillbirth, whereby women perhaps who find it more difficult to attend antenatal appointments with their midwives, when you can pick up some early things regarding reduced placental blood flow or complications of late pregnancy, which are picked up by those midwives, and those things are often missed if the woman is unable to attend those appointments. So whilst we welcome the reduction in stillbirths, I would hope that some of the work that Sadiq is doing about addressing maternal weight and highlighting the issues of poverty and income inequality, and hopefully improving the pay of Londoners by getting London to be a London living wage city will contribute partly. I think also Sadiq's role of challenging the NHS and perhaps taking the information that might come from this forum about other things that we can do to reduce further stillbirths, and taking that back to the NHS on behalf of Londoners. And that idea whereby, Sadiq is meant to challenge the NHS, which normally it works fantastically, but often it itself knows it can do better. So whilst a couple of things that I mentioned already on income inequality and weight, Sadiq is doing directly, but indirectly, I think perhaps he could use his role as the voice of Londoners with the NHS about other areas that are identified by this forum accordingly.
How about any specific campaigns? I used to work with a particular campaign doing VR training for expectant mothers, midwives and nurses around the baby's experience in the womb, and it was one of the most moving pieces of training you could do. Is there any role that the Mayor could do in providing further kind of innovative training or campaigns? Do you think there's a role for the Mayor there?
I do actually, yeah. I think Sadiq also welcomes the opportunity to amplify messages to Londoners which perhaps aren't always out there, particularly to Londoners perhaps who don't always receive some of the information from the standard kind of routes and channels. So therefore, if there was a campaign on stillbirth and what can be done to improve outcomes in maternity services, I think Sadiq would probably welcome the opportunity to take part in that campaign, to highlight it, to use his media voice to get that message across. So if that can be shared with me, I can then pass that on, and we can perhaps take the opportunity to do what you suggest.
Hopefully that's something that emerges from this evidence gathering session. So I'm glad that you are up for that. The Healthy Early Years programme, you said obviously it's specifics on the school readiness, and I just wanted to really touch on the fact that part of it should be really on the first 1,001 days, which obviously starts well before birth. Do you think enough focus right now is on that? And if there isn't, could we perhaps reflect on what more is done in the Healthy Early Years programme at the prenatal period?
Yeah. So at the moment, the programme is very much based on those early year settings. So, and it's kind of 1 o'clock hubs, nurseries, childminders, etc. And I think most of those probably don't start until the child is probably about 6 months old. And up the first 6 months, the input the family gets is very much from the midwife and the health visitor and myself, like the GP, etc. And I think recognising that first 1,000 days, and people would say, this is when you have the biggest opportunity to mould a person for the rest of their life. So we start at 6 months because that is the settings we work with. We work with those settings and give them a curriculum so when they're looking after those very, very young Londoners to make sure they are prepared for school and life thereafter. But so therefore, if we were to adapt the programme to look at before 6 months, we'd have to change the programme from a settings-based project to a project working very much more generally with Londoners, because we'd have to be reaching out to Londoners accordingly. So we could consider that, but we are doing a review actually at the end of this year for the healthy early years. But I think it would be quite a significant change to what it's done, what it does at the moment. But it definitely, there is evidence, I think, to support what you're saying, because we're missing that first 6 months in a child's life. And we'd have to look about how we could do that practically. So definitely one to consider, but I think because of the way we work with settings at the moment, that's why we miss those first 6 months, probably.
Thank you. And I'm guessing that the Deputy Mayor for Children and Families will be part of that discussion.
Yeah. So yes, definitely. And
Okay.
and we share this work together very much.
Perfect. Sorry, 2 more questions, Chair. Try and be brief on them. You did kind of touch on this earlier. Obviously, I don't think I need to rehash the statistics too much, but just say obviously 8 in 10 mothers did say that they had mental health challenges during their pregnancy. And you've already touched on how the wellbeing champions could perhaps tackle that. But I was more interested if you could perhaps talk more about the specific training or specific way in which those wellbeing champions will be able to work with expectant mothers, touching on obviously the training and how they'll be ready to do that, and the kind of environments that they'll be able to come in contact with them.
Okay, so the one that probably I know best about is mental health first aid, and that's kind of quite a detailed programme. It takes about between some mini ones do 4 hours, some are 3 days, and that's very much a programme whereby you're taught very much to identify mental distress, and then both to support that person and to navigate that person to services, because so often what will happen is that a person, let's say, I'll use an analogy here about people do their St. John's Ambulance physical training. You kind of twist your ankle, you know what to do. But the majority of people, when you see someone at work or in a community is having obviously a mental health crisis, what do? How do we talk to them? How do we identify which people perhaps are in such level of distress they need emergency services, which people just need some support, which people need counselling? And so I would hope that a programme like that, can work with women who are pregnant, and as I think you've mentioned earlier, that pregnancy in itself can be very stressful. It's a fantastic experience, but very stressful. Being a young mum is phenomenally stressful, and it's got its mental health consequences. And so I would hope those people who are mental health first aid trained are able to work with those people in their community. What we haven't done is, and I don't think there is a mental health first aid programme tailored for working with women who are pregnant or have got young children. But the mental health needs are very similar, but just amplified in that community. So that's, I suppose, one area. Suicide prevention, again, that's about very much how you can talk to people who are expressing suicidal ideation, and not to believe that by asking someone are they thinking about suicide will make them do it. That is the opportunity that is so often missed, because you're worried by raising the issue, you're going to trigger an event. The total opposite is true. So trying to do that kind of training to people who sadly sometimes take their lives, I think will have a significant impact. So it's more that generic approach, which is perfect to deal with women who are pregnant and having young children going through those mental health stresses that you can do in those situations.
Just should there be more specific training? Because I think it is a very particular need for parents to understand. Is the hormones alone will bring these mental health challenges themselves, and I don't think many people understand that as well. So it is a specific kind of challenge that people face, and I think as well, obviously the rhetoric around it being the best time of your life, and people often that in itself causes the concern, why is this not the best time in my life? Why do I not feel like that? So it's a very specific challenge. So do you think there should be more tailored?
So yes, I think that there definitely could be, and I do get that point whereby often the expectation is that you're going to feel fantastic. You don't, and then you feel that there's something, there's a massive mismatch there, and it's hard to talk about it because you're meant to be, the happiest point of your life. And we could go back to the mental health first aid team. There's a national team to say, do you want to do some more bespoke, training, so for people perhaps who, especially people who are working in that environment, to say that, would you want to do mental health first aid training, and do a program which has got a more tailored curriculum. At the moment, there is a standard curriculum which everyone does, and I think what you're suggesting might be useful. It'll be for a very small group, because you have to work out what kind of people in their working and daily environment are, are in that working in that area who could benefit, who aren't already professionals, who get lots of training already. But I think I could definitely take that to the national program team and see what they say.
Thank you. And just one final question, Tom, more on this is a workforce point. I spoke to a number of healthcare workers, some of the midwives, who are struggling with the new £12.50 charge to get to work, because there's, where I live, I've got Whipps Cross and North Middlesex Hospital, which are just over the boundary of the A406. This comes with, separate challenges that they're facing on the cost of living crisis, and it's adding to that. Has there been any work, or should there be any work, on how these kind of charges, and I'm sure I know less about it and have encountered less specific cases about the congestion charge, but I'm sure there's also people facing that challenge with the rises there. Has there been any work on what these policies are doing to our healthcare staff?
So we've had discussions with the Royal College of Nursing about this issue, and I think the first point I'd always make is that improving air quality of London improves the health of all Londoners, whether you work in the NHS or not. So therefore, it's not as if people who work in the NHS go along a certain line whereby their air quality is better than everyone else's. So doing that kind of work is vital. And but I think that a discussion between the NHS as their employers and us to see how can we work together to ensure that we can address some of those issues. I don't think necessarily we as the GLA and as TfL would start saying, okay, these people don't have to pay the congestion charging, and then all of a sudden, there are many London workers who would feel that, they are also facing financial challenges because of the state of the economy at the moment. But we have had those discussions, and those discussions are ongoing to see what we can do to, make sure that, workers in London, are supported accordingly. However, doing anything which would worsen air quality would not be the right thing forward.
Thanks. And I'll just briefly say on that point, I think it's very important to the conversation that the reason that it affects, our healthcare workers is because they are so often shift workers and they really don't have another choice. So just to put that in there, I do think it's something that we should look at much more closely and the effect on them.
Thank you.
Thanks.
Thank you. We're going to move on to Assembly Member Russell, who will also be asking some questions to the virtual guests. So just want to make sure that you're ready in the ether.
Thank you, Chair. And yes, hello everyone online. So this section of questions is looking at the impact of the pandemic on maternal health and care. And my first question, which I'm actually going to put to Tinuke, who's in the room, and then I'll be coming to everyone online with the same question. So what impact did the pandemic have on how maternity services were delivered in London? And what impact did these changes have on the experiences of people who were pregnant during the pandemic? So, Tinuke.
Thank you so much. Thank you for inviting me and my colleague Chloe, who's in the audience today. So we founded 5 Times More, obviously, in 2019, following a traumatic experience from myself. And, I wanted to, before talking about the experiences that we were able to capture, in our survey, I did want to talk about a little bit more about my experience. So when I gave birth to my second child, it was during the pandemic. Okay, I've had to write it down. I will be reading because I don't want to forget anything. But I gave birth to my second child in April of 2020 after the first lockdown. And my experience of labour this time round, despite it being a lockdown and being terrified of going into hospital, it was largely a positive one, which is a win. But this was due to me having quite a good understanding midwife who made me feel in control of the whole experience. And this was obviously coupled with the fact that by this point I had been running 5 times more for a few years now, so I was a lot more confident in my rights and knowing what to ask for, and just being a better advocate for myself compared to the first time round. Prior to me going into labour, however, my experience was not a positive one. The last scan I had at 37 weeks, I had to go in alone, and I was told that my baby's head was measuring small. I was really scared because that was all the information I was given, and I was asking for more information, and they couldn't give it to me, and I was waiting for a long time. I was obviously alone, and I didn't have my husband, so I was frantically searching on Google as to what this meant. Because they couldn't give me a straight answer, I had to ask for a second opinion from another doctor. It did feel like a really stressful situation because at the time we weren't quite in lockdown, but you go on the news every day and you hear of so many people had died from COVID. So it was just a really, really scary time. This was around March of 2020. I felt like I wasn't supported because I didn't have the support of my husband in the appointment, and I wasn't satisfied with the answer I was given. I was also scheduled to have a home birth, which was cancelled in that same week, as the team in charge of home births had to shut down due to COVID numbers increasing and not being able to get support from the ambulance services. I wanted a home birth because of what happened to me the first time round. So I was quite devastated, being told my baby's head is measuring small. I can't go and have a home birth. But thankfully, I was able to have a good experience in the end. I did want to read a couple of experiences from our Black Maternal Health Experience report. So we launched a report in April of last year, and we gathered over 1,300 responses from Black women across the country, making it the largest piece of data on Black women's experiences to date of maternity care. Now, in that survey, we captured a mixture of quantitative and qualitative data, and hundreds of women who were pregnant at that time, or who had given birth in the last 5 years answered the survey. So I just wanted to... I had a nurse... I'm just reading some of the quotes now. I had a nurse shout at me that I tested positive for COVID on the delivery ward. Because of COVID, the breastfeeding centres and droppings were closed, so I couldn't access NHS support for the first week. I really needed help with breastfeeding, and I just didn't get it at all. And I was upset at the time because there was just no support available, and it was my first time. I was induced during COVID, so I was in a room full of other women. I felt like I wasn't seen too much, and as I was ready to have the baby, I wasn't listened to until I was literally crowning, so I couldn't call my partner in time. I had an assisted delivery. I believe because I was staying so calm, I was overlooked, and they all kept saying how well I was taking it and that I could handle it all. I felt that everyone was really hands-off, and this was probably due to COVID. I had missing notes and problematic appointments with minimal information, and this made the whole experience feel a bit impersonal. COVID impacted the quality of care offered, especially in the third trimester. I had some issues that led me to be induced, and I was told I had to be alone, and this caused me a lot of anxiety, especially because of the statistics against Black women in maternity. So just, even though it was, for me, my experience was weird around the 37 week, having that, being told my baby's head was small, then my home birth being cancelled, having a largely positive experience. But then after that, I wasn't seen. I wasn't seen by the GP. I wasn't seen by the health visitor. Every time I would call, I couldn't get through to anyone. I was specifically told, don't come to the GP if you because it's COVID times. It was really serious. It was April, so right at the height of the pandemic and the first lockdown. So I feel a little bit fortunate that it was my second time round, but had it been my first time round and I didn't really know much, or couldn't really see if there was anything wrong, I think I would have been absolutely terrified.
Thank you. That's given us all a very vivid picture of the experience of people being pregnant through particularly that early bit of the pandemic, when everyone was, I was just remembering back the other day, it was a really frightening time because nobody knew exactly how things were going to work out. We didn't even quite know how to treat people with serious health outcomes from COVID, and just remembering back to that fear, and you've given a very vivid picture of the experience of people going through that. I'm really aware I want to bring in the people who are online, but I just wondered, Suzanne, if you just wanted to come in very briefly with a sort of midwife perspective on that relates to what we've just heard from Tinuke.
Okay, thank you. And I've heard Tinuke on more than one occasion, and it's always, every time, it's such a powerful story. And I think what 5 Times More have done and what Birthrights have done over the last year about giving voice to women whose voices haven't been heard is something that we should all really celebrate and really be really thankful for. I'm also really thankful to have the opportunity to talk to you. More than 110,000 women in London have a baby every year. So, and we're an unusual service because we start off with 1 person and we end up with 2. So actually, every year, almost 250,000 Londoners are using maternity services. So over the course of the pandemic, that's an awful lot of people. And I think what I'd say is that the maternity services in London, as in the rest of the UK, were not in a good place before COVID. They had been understaffed and underfunded for many years before. And so they were not in a strong place and they didn't have a lot of resilience to be able to respond to the pandemic. The most telling thing, and I think it probably underlines everything that Tinuke said, is that we lost so many midwives who were themselves sick or were self-isolating. And at its worst, there were maternity units whose staffing was 40% down. When you're running on a service that has got less than half the staff it should have, then all of those things that are cancelled, those are the real, what Tinuke has done is shown actually what that actually meant. We'd worked really hard to make sure that maternity and midwifery was ring-fenced and that midwives and support workers did not get taken to other parts of hospitals that, of course, were under pressure, because obviously the babies didn't stop coming during COVID. You can't reschedule, you can't postpone, you can't ask people to come back in a few more months. But services did have to be rationalised, and Tinuke's experience is not unusual. Home birth services did have to close because the ambulance services couldn't get to them. Co-located birth centres did close. None of these things are things that midwives would want to see. And Tinuke has talked very eloquently already about the injustices for Black women, Asian and minority ethnic women. I would also add to that those staff groups. In London, our midwives and support workers, we have a much higher proportion than in the rest of the UK of Black and brown midwives and support workers. Their experience of COVID kind of mirrored exactly what we know about the injustices more widely. I think the other 2 things I'd just say about the working through the pandemic is we had very confusing advice both from the government and from NHS England. First of all, on working women, pregnant working women, and then we had contradictory advice on pregnant women generally and COVID. And for a lot of the time, it was the Royal College of Midwives and the Royal College of Obstetricians that stepped into that space and tried our best to give women which is women using the service, but also the women who work in the service, to try and give them advice and guidance and a steer. But that was a constantly changing and really confusing time. And it made it very difficult to give women sensible advice because things kept changing. The final thing I'd say is that I think one of the worst things of all was that the pandemic ended up pitting midwives against women, particularly around this issue of visiting. No midwife would ever want to stop partners being involved in care. But that balancing of the needs of the individual woman in front of you and the whole service, scan rooms that don't have any ventilation, you have to keep the staff. We had to keep staff safe because we were already so short of staff, and it was horrible because it pitted women against midwives in a way that's never happened before. And I think we've all got a lot of rebuilding of trust to go on.
Thank you. Now, I wish I could stay. I have to go to a police briefing. And so I'm going to have to hand the question back. Question 7, I'm so sorry. I will watch back afterwards to hear your evidence. But Chair, if you can pick up this question 7 with those 3 online, that would be much appreciated. And many apologies that I have to leave.
Thank you. And I understand Dr. Coffey needs to leave
Thank you very
as
much
well.
for your time.
That's okay. I'll turn to Joeli online.
Hello everybody. Thank you for having me. I didn't actually hear the question because the sound cut out, but I'm here anyway to tell you about the experiences of pregnant women during the pandemic in maternity services. I'm very pleased that it's been picked up on the confusing advice that working pregnant women had. It did take the government 9 months to publish any specific safety guidance for pregnant women in the workplace whatsoever. I mean, ironically, you could have had a baby in that time. And that was also something that we were working hard to try and communicate with pregnant women. Maternity services is not something that we usually work on. It's not part of our remit, but because the situation became really quite dire and we were being contacted by so many women, we felt that we had no choice but to try and do something about it. And so part of our work was doing regular surveys with pregnant women and with new mothers about their experiences in maternity care. And obviously the big issue for these women was that birthing partners were not allowed to many scans, to appointments, and for the duration of labour, as well as on postnatal wards. And although we understand that these were obviously medical environments, there were vulnerable people in the hospital, the staff were vulnerable, and they needed to be protected, and pregnant women themselves are obviously extra vulnerable because they're more likely to die should they become infected with COVID, and their baby is more likely to be born prematurely. We do feel that there was a lack of evidence as to why partners were not allowed into the hospital. And we also know that the research is very clear that should a birthing partner be allowed to accompany a woman, that the outcomes are much more positive for the baby and for the pregnant woman. And we also know, as has been said, that suicide is the biggest killer of new mums, and that improvements in care would have potentially prevented suicide in 67% of women. And we also know that requests for mental health support amongst pregnant women has increased dramatically since 2019. And we were regularly saying, forewarning, that this could be a mental health crisis if birthing partners were banned from maternity wards. And I think we are starting to see the impacts of that. And I think it's something that urgently needs to be addressed. A lot of this data that I'm going to tell you is national because we're a national organisation. But, obviously this affected London as well. So what we saw were that 17% of women felt forced to wear a face covering during childbirth. That figure rose to 23% for Black and brown women. And that was whether it was a C-section or whether it was a vaginal birth. But some women told us that that obviously restricted their breathing, which is critical when you're giving birth. Some women told us that they vomited in their mask because it was restricting their breathing so much, and that they felt that this was dangerous because it inhibited their ability to communicate with the midwife. And of course, for Black and brown women who, and we know the data on mental health outcomes for this group, that felt even more terrifying, to be unable to advocate for yourself, to literally have your communication restricted. Our data found that 7% of women gave birth without their partner. Some women complained of being left on labour wards alone for hours at a time in pain. They had no partner, there was no midwife in sight. Obviously, we've heard that midwifery units were massively understaffed, and that's the reason why. In 2020, we polled 4,000 women who had given birth in the previous 4 months. 60% of respondents said their partner wasn't allowed with them when they were induced. Of those, 30% said they were in hospital for 48 hours or more without their partner. And almost all of these women said that that was too long. 25% of those who went into labour naturally said that they had to spend some time without their partner on the labour ward. Of those, a third spent more than 2 hours on their own. 18% spent more than 6 hours on their own in labour. Just half of the women who spent time alone whilst in labour said they felt listened to by medical staff. It was just half. The good news is that 84% of women said they felt safe whilst giving birth. However, this reduced to 77% for Black and brown women. Part of the issue was that there was often confusion over the guidelines. We heard this quite commonly, that the guidelines would change regularly, and this wasn't effectively being disseminated to the staff. So we heard of a woman who birthed her daughter alone via a C-section after a short induction, and her partner was ready to come in. He was dressed in scrubs but was told he wasn't allowed in, and when they asked why, they said it was confusion over the guidelines. A fifth of mums who gave birth felt forced to have a vaginal examination due to the restrictions, and that rose to a quarter of Black and brown women. Many hospitals stated that partners couldn't come into the labour ward until a woman was 7 centimetres dilated, like established labour, which is 7 centimetres dilated. And so they were saying you have to have a vaginal examination in order to signify whether you're in established labour. So 82% of the women that felt forced to have a vaginal examination stipulated that this was so that their midwife could determine whether they were in established labour. I mean, this is somebody putting fingers in the most intimate part of your body. So, I think this is quite serious data and should be considered further. There was also a spike in the number of women requesting elective Cesarean sections because women knew that their partner was more likely to be allowed with them into theatre. So women were requesting severe surgery simply so that their partner could be there. 24% of respondents that had a C-section, 15 of our respondents said they had a C-section, and 15% of those said they opted for a C-section simply so that their partner could be there. There was also a spike in a request for home births, and of those 70% who requested a home birth said that they did so just because they knew that that meant that their partner could be with them. 90% of pregnant women said that restrictions had a negative impact on their mental health, with 97% saying that the restrictions increased their anxiety around childbirth. Then there were the babies who ended up in the neonatal unit, which is clearly very traumatizing. You've just been through birth and then you're told that your baby is sick and they're taken away from you and taken to the neonatal unit. Research by Bliss found that parents are 70% more likely to say they found it difficult to bond with their baby if the neonatal unit where their baby was being cared for put time limits in place. And this was something that was commonplace during the pandemic. Our research with over 4,000 women in 2020 found that for mothers who had a baby who ended up in the ICU, 11% said they couldn't visit their baby. 11%. And 18% said their partner could not visit their baby. Almost half said that they weren't allowed to visit their baby as a couple. Postnatal wards were often where things started to really go awry for women. 12% of women said they were prevented from doing skin to skin, something which has shown it vastly improves health outcomes for a baby. 20% said their partner was prevented from doing skin to skin. Fewer than half of women said they had the support they needed to breastfeed. On the postnatal wards, 1 in 3 said there was no visiting on the postnatal ward whatsoever. Of those who said their partner could visit, 44% said they could visit for fewer than 2 hours. A quarter of mums said that their most basic needs were not met on the postnatal ward. That's food, water, and pain relief, a quarter. 86% said that having their birth partner with them would have made a difference to how supported they felt. In scans, in January 2021, we polled over 7,000 pregnant women, and 22% of them told us that their partner had not been allowed to attend any of their scans. 9% of women said they had been given bad news when they attended a scan, and 3/4 said that they were on their own when they got this bad news. I want to just, if I may, just tell you 3 stories, because I think it's really important we hear the women's voices of what happened during the pandemic in this.
I think just conscious that we've got other guests as well that want to come in, so I'm keen to hear from them as well. But we'll come back to the stories later when you come for your next contribution. So I've got also on the call Maria.
Hi there, can you hear me okay? So I'm Maria, and I'm Programmes Director of the charity Birthrights, and we aim to improve maternity care through a focus on human rights. So thank you very much for inviting us to give our perspective today. I think Joeli's covered a lot of the issues that we saw during the pandemic too through our advice line. We got an over 300% increase in inquiries to our advice line during the pandemic. I think it's important to remember that as Caroline has said, at the beginning, this was a very new and difficult situation for staff, particularly at the beginning. And we really want to pay tribute to the thousands of maternity staff who worked throughout the pandemic, and the exhaustion and the burnout that they're experiencing and continue to experience because of ongoing staffing shortages. So that's the context we're talking about, and when we do recognise that difficult context. But I wanted also to start by focusing on some of the positives that came out of the pandemic. So some of the staff we talked to have described a time at the beginning of the pandemic when bureaucracy disappeared and new things were possible. So one member of staff talks about the fact that she tried to get a door for her birth centre for 3 years, and then suddenly when the pandemic hit, that money and that resource was available, and it just got done. And also things like greater use of induction methods that could be started at home. We used over the pandemic, which is a positive thing for women and birthing people, and we hope that some of those innovations will be kept. And there were some maternity services in London and across the country, but in London in particular, that responded fantastically to the pandemic. And I just want to single out 2, although I know there are lots of other examples. So as Joeli has said, one of the first big impacts of COVID was that we saw trusts centralising maternity services. So because of ambulance service issues and staffing shortages, a lot of home birth services were withdrawn, and a lot of midwifery-led units were closed or taken over as COVID wards. But some trusts really bucked that trend. What women were being told was that they should stay at home, and that resulted in an increase in demand for home birth and out of hospital birth. And Chelsea and Westminster really responded to that. They already had good continuity of care teams in place, so that meant that midwives knew the women and birthing people they were looking after. They had that trusting relationship. And they actually went as far as putting in place a private ambulance service to ensure that they could respond to that increase in demand for home birth. And the other main issue that we saw throughout the pandemic, as Joeli has highlighted, is the changes in visiting restrictions that impacted so detrimentally on families. But the Whittington in London kept 24/7 visiting for partners throughout the entire pandemic, and second birth partners for most of it. And even now, children and parents of mothers who've given birth are allowed on the postnatal wards, which is still quite unusual at the moment. So I think it's really important to say that these positive examples did exist and things could be done differently. In both those cases, I think that resources and estates played a part, but I think that leadership was also absolutely critical. So the director of midwifery and her team at Chelsea and Westminster went out of their way to ensure that their care remained as rights respecting as possible. And the obstetrician who was in charge of the pandemic response at the Whittington was a specialist in working in humanitarian disasters. So he had experience of working in Africa, for example, when the Ebola epidemic was there. And he really took the lessons from that. He said that even during Ebola, they did not stop visiting for pregnant women because they realised how important that was. That support and that care was really crucial to those pregnant women. And when you have other infection control measures in place, such as hand washing or PPE, the actual marginal gain from getting partners out of the building is quite small compared to the impact on the people affected, which is absolutely huge. So those are two really good examples. But I think it's fair to say that across the board and in general, we felt that the response to COVID by maternity services was not proportionate, and the evidence for the restrictions that were put in place was missing, as Joeli has said. I just want to say a little bit about the human rights framework and how it can help organisations to make these decisions in times like a pandemic. So the human rights law reminds us that there are some rights that are absolute and should never be violated, even in a pandemic. So the World Health Organization made clear right at the outset that pregnant women and birthing people always have the right to be treated with respect and dignity. They always have the right to have a companion of choice, to have clear communications from healthcare professionals looking after them. They should have access to pain relief, and they should be able to be mobile in labour and give birth in their position of choice. And in addition to that, under Article 8 of the European Convention on Human Rights and the Human Rights Act, which is the right to private and family life, women and birthing people also have the right to choose the circumstances of their birth. So that means choosing who's with them and where they give birth. Now, the fantastic thing about the human rights framework is it's flexible enough to recognise that there are some circumstances in which those rights need to be restricted. And we would recognise that in the pandemic, the need to protect the public health of others was a valid reason for some of these restrictions. But crucially, the restrictions need to be proportionate. And that's, I think, where there are real lessons to be learned. And perhaps as Joeli didn't get to share some of the stories, I could just share a few stories that we heard during the pandemic with you. One of the worst impacts of the pandemic was that some women ended up giving birth on their own. And I wanted to tell you the story of Laurel, who gave birth at the Royal London in the summer of 2020.
I'm just going to pause you there, because the next questioning I'm going to ask about the impact of Emma's going to come in to ask about the impact of the pandemic, so we'll bring in the examples at that point, but for now I just want to hear from Marilena on this as well. Eva, if you'd like to unmute.
Hi. And apologies, may I just ask you to repeat the question, because I had to step out for a few minutes, although I did hear some of the really powerful testimony about. was being mentioned, and I really wanted to start by acknowledging the powerful testimony because it's so incredibly moving.
Sure. The question originally was, what impact did the pandemic have on how maternity services were delivered in London, and what impact did these changes have on the experiences of women who were pregnant during the pandemic?
Thank you. As you know, during the pandemic, we started off being PHE and then moved into the Office for Health Improvement and Disparities. And part of our role was actually to pull together the evidence about the impact of the pandemic on pregnant women and suggest potential interventions which we thought the evidence would suggest would help. So whilst we worked with the NHS, we weren't responsible for health service provision during the pandemic. And I just want to go to some of the findings that our report found about the impact of the pandemic on women. And actually what it did do is it highlighted those health inequalities, which have already been mentioned already by Tom and by others during this session. The most important impact which we were able to find was about the impact on maternal deaths. And although pregnancy is incredibly safe in the UK, the Embrace report into COVID-related maternal deaths shows that there were 17 deaths. And of those, compared to the general population, non-white ethnicity was heavily overrepresented in those deaths. And again, in a similar way to the disparities that we have already found, the outcomes in general were not equal. So there remained gaps between women from deprived and affluent areas, women of different ages, women from different ethnic groups, and also women with learning disabilities, and pregnant women could face more than one type of vulnerability as a consequence of these vulnerabilities. With respect to the actions that we thought would be useful and we would suggest in terms of minimizing the risk to, in particular, women in Black, Asian and minority ethnic groups, we suggested from our evidence that there was a need to increase the support of at-risk pregnant women, to reach out and reassure women with tailored communications, to discuss supplementation and nutrition with all women, and to actually improve recording of risk factors in order to identify those women who are at risk of poor outcomes, to develop services for them. I think key to all of this is that we are and we were all part of the solution, but the most important thing was listening to women and their families. And I think the testimony today is actually a testament to actually how on occasions we needed to do better for women and their families. I know there are lots of examples where we did well, but I was actually very saddened to hear the stories which have been mentioned today. Thank you.
Thank you. I'm going to turn to Assembly Member Best.
Thank you. I was going to ask what the pandemic-related changes to maternity services in London, whether they were felt equally or did it impact some groups more disproportionately? And perhaps, Tinuke, if I could come to you first, and then come back for some of those personal stories that you were about to say earlier, the guests online.
Thank you. So in terms of, the impact, it was quite a lot, especially in the Black communities. And I'll start off, obviously people were really scared of going into hospitals. A lot of people have mentioned that the prevalence of COVID was higher in the Black community. And then the Embrace report that came out saying that if you basically are not white, you're more likely to die if you're pregnant and you're Black. That, of course, can put the fear of God in anyone. So people were already scared to go to the hospital and present at the hospital and present at any type of settings when it came to just being checked out, that kind of thing. People were genuinely frightened, even though they wanted to go. Like we said, there was an increase in people wanting home births, like myself. So people were really scared. People, more likely to be admitted into hospital if you were black and pregnant with COVID. It just meant that there was a lack of trust in the community. There was no clear information. Like you said, there was so many different guidances, and if you weren't on the ball, you would kind of miss that kind of information. And having your partner there, not having your partner there, being able to do things that were, considered to be normal, and then you can't do them anymore. And, you can have a water birth. No, you can't have a water birth. This has been taken away. It was all just very confusing. And we were just hearing a lot of black women at the time just being really worried, because it was almost like there was a double layer, more likely to die as a black woman anyway. And now there's this COVID that's going around. A lot of women were saying that their birth choices obviously were not being met, and because there were, so few face-to-face interactions, and they were digital, a lot of women in general, a lot of black women, especially through our report, were saying, look, their birthing options were not explained to them, but this was further exacerbated within the pandemic because there was not a lot of face-to-face interactions, and those interactions were often digital and rushed, and they just didn't feel like they got that time. So obviously, if you don't know much about your birthing options, then your choices are quite limited if you don't know what's available to you. So you don't have the agency to sort of ask for other options if those were even available. There was a lot of contradicting information about vaccines, and obviously there's already vaccine hesitancy in the black community. They were told not to take it, then they're prioritised for it, and it was just a really confusing time. A lot of people were very sceptical about taking it, and this just led again to a lack of trust and just a lot of confusion as to, well, I'm black, I'm pregnant, I'm vulnerable, should I take this vaccine or not? So that was something that we were hearing time and time again, especially running the campaign. Those are just some of the things here. Maybe if I go through some of the other experiences to sort of bring this to life. So the hospital did not inform me of the new COVID-19 rules required, and was unable to provide me with a woman sonographer, and I was not comfortable with having a man. COVID impacted the quality of care that was offered, and in the third trimester I had some issues. I think I've said this one already, but it caused a lot of anxiety, and I think COVID is an excuse to provide less care. I don't feel that my midwife I don't feel my midwife cares, and I feel like my current hospital at my current hospital, I have to question everything because nobody seems to be accountable for anything. I'm always chasing things up, and this makes me feel really nervous to give birth in hospital. So those are just a couple of examples just to kind of back up what.
Thank you. Thank you. And I'll, if I could go to Joeli next online, please, because now you've got to go.
Hi. I just want to, I haven't got the data on me about vaccine hesitancy, but that also was something that we worked on. And a big part of the problem was that there was no government drive to get pregnant women vaccinated when we had enough data to show that it was safe, the vaccine in pregnancy. The language was very much, you can get a vaccine if you want to. There was no push like we saw in other countries. And so vaccine uptake rates amongst pregnant women were very, very low, and particularly amongst Black pregnant women, which actually, had they had the vaccine, in some cases could have saved their lives. And we do know that Black pregnant women were more likely to die. Indeed, the first 2 deaths were Black pregnant women. The first 3 deaths, a pregnancy and contracting COVID. So the fear amongst the Black community was enormous. And as I've seen, we've shown from the data also some of the, the outcomes, the pressures on Black pregnant women when they were in maternity units was greater than it was on white pregnant women. So yeah, I would, if I may, I'd just like to read a couple of stories to you that we've received. So Becky, who gave birth at North Middlesex Hospital, said to us, she was bleeding while pregnant and having to attend scans alone to find out if her baby was okay. Being alone whilst finding out my baby wasn't growing at the right rate and being told I'd have to be induced, not being allowed to even video record or call my husband whilst having scans, making the decision for my baby to have a lumbar puncture for suspected meningitis while I was alone and was on morphine less than 24 hours after my C-section, spending a week in hospital while my baby and I were sick with group B strep and sepsis, and I was recovering from major abdominal surgery, and my husband was only allowed to visit for 1 hour a day. There were no baby groups, no antenatal classes, no baby shower, no shopping for maternity clothes or baby items, no pregnancy yoga, no pregnancy massage, no visitors, no in-person doctor appointments, no hope. Nicola said, I laboured for 5 hours alone in a triage bay in Queen Charlotte's Hospital whilst my husband sat in the car park. Only then was I told they did not have any beds and I should make my way to St. Mary's. I was in labour and wasn't even asked if I could get there. I had a traumatic birth and had to go to surgery for 90 minutes post-birth. I then had an hour with my newborn baby and husband before he was told to leave as I was moved to a ward. I arrived in the ward in darkness. I had an epidural for the surgery and I couldn't feel my legs. I had a catheter. I felt totally alone and abandoned. The baby started crying and I called for a midwife using the buzzer. I was quickly told off. The baby had pooed and she was cold. I had a bag full of nappies, clothes, wipes, but physically I couldn't move from my bed to do anything. I felt I had failed at my first test of being a mother. I was too scared to call for a midwife again. I was scared I wasn't looking after my baby properly and that I wasn't fit to be a mother. Daisy said, I gave birth in June 2020 during the first lockdown and had to stay in hospital with my baby for a week afterwards. I wasn't allowed one visitor, not even for an hour. I could see my own mental health declining as each day passed, and having someone just for a few minutes to offer respite and comfort would have changed the game for me. I struggled postpartum. I was diagnosed with postnatal depression and still haven't come to terms with this period of time. No one, particularly those recovering from birth, sleep deprived and scarred, should be forced alone to navigate the early days of parenthood. Thank you.
Thank you. Maria, online, you are still there. Just wanted to, you can obviously add anything to that question as well, but I wanted to ask you specifically, your website helpfully identifies where problems have arisen within trusts across England. And I wanted to know what you've done as an organisation to try and help new mothers that have raised concerns with you, what you've done to raise those with the trust and how responsive the trusts have been.
Thank you. Yes, we've been contacted over the last 2 years by thousands of women who've had the kind of experiences that Joeli has just outlined, and they're really heartbreaking to hear. I mean, even just this week, we put out a call for some further stories with our colleagues at Make Birth Better for a project we're doing with the Ombudsman to do a review of the kinds of issues faced by women and birthing people during the pandemic. And that post got an instantaneous response within minutes, with people kind of pouring their hearts out about the separation that they'd experienced from their babies, their kind of postnatal experiences that Joeli's just described, where they felt unable physically to care for their babies, and yet their partners weren't allowed in for very long at all. And it's obviously such a raw thing still for many people, even though some of those women gave birth nearly 2 years ago. So some of the things that we did as an organisation were we worked really closely with organisations like Pregnant Men Screwed and other partners in the But Not Maternity Alliance to raise awareness at the national level of the impact this was having. We wrote a number of open letters to the government. For example, we had one of the Pregnant Men Screwed surveys published alongside an open letter in the Mail on Sunday, which resulted in some further guidance being issued to trusts. So there was that advocacy going on at the national level that we were very much helping to lead. But at the same time, we also advocated at an individual level as well. So where people would come to us and they say, we've raised this with the trust, we're not getting anywhere, we would write to the trust concerned and raise that. I would say that sometimes that got a really positive response, or at least we got an exception for the person concerned. But in some cases, we got a fairly blanket response that they were taking safety into account and trying to make the best decision that would keep everybody safe. But as we've raised, our concern is whether that decision was reached in a proportionate way, and whether all the right factors were accounted for in that decision, and whether people were really looking at the impact it was going to have on people in a long-term way, on the mental health of people and on the physical outcomes of people, as well as just looking at infection control, which seemed to be the predominating factor. I just wanted to return briefly to your question about whether the impact fell equally on all women and birthing people, and just to highlight an issue particularly about interpretation services. So this was an issue we identified as really coming out of the pandemic, although it was highlighted in our racial injustice report as well. But one of the things that we see in the NHS is that they often rely on partners or the person coming in with a pregnant woman to be the informal interpreter. And when that's taken away, there's a huge impact on whether that woman can communicate with staff or understand and participate in decisions about her own care. So we had a woman contacting us who was Spanish speaking, spoke very little English, and she was receiving care from Guy's and St Thomas's. This woman had a history of mental health issues and was a survivor of abuse. And she had no family in the UK, but apart from her husband. And this woman had been allocated to a continuity of care team at the outset of her pregnancy, but that continuity of care had been taken away because of the pandemic. And the couple repeatedly asked if the husband could attend appointments or at least attend on the phone to help with interpretation. And they were assured at first that wouldn't be a problem. But when the woman came for an important appointment at 7 months, the husband was turned away and refused a video call. And there was no phone interpreter present, and only Google Translate was used. So that woman later reported that she had no idea what was going on at the appointment. And she had requested a phone interpreter, but was told it wasn't normal practice to use one. And that couple completely lost faith in the maternity services to be able to support them, and were even considering giving birth without any assistance as a result. We had similar stories of women reporting that they saw women in the beds next to them who couldn't speak English, being told there weren't translators available. And one woman reported that she saw somebody else on the postnatal wards having been sent home, knowing that there had never been a decent two-way conversation between the healthcare professional and the woman. So I think interpretation services are a really important issue that we need to focus on going forward.
Thanks. I want to come to Marilena, and come to you first, Marilena, but perhaps I'm going to come back to Maria as well. What I'm kind of focused on is what we can do. So I'd like to know from both of you if you have spoken previously or written with this evidence to either the Mayor of London or the Deputy Mayor for Children and Families to ask what advocacy and convening powers they can use to support better maternal care, and with the issues, were these raised to them? And the second question that I'd like you to think about is, what's the situation now? How many of these kind of historic, almost COVID practices are still being used or still being raised with you, that people are experiencing them, that need to be ditched? Marilena, did you want to speak first on that?
I'll speak first. I think I can probably answer the first question better than the second question. But again, I just wanted to acknowledge those powerful stories before I even start. I think with respect to what we're doing around advocacy in London and to ensure that the lessons have been learnt, as you're well aware, Tom mentioned this earlier in his evidence briefing, poor maternal health care is associated with poor outcomes for babies as well. And in London, what we have seen is even though infant mortality rates in London are low compared to the rest of the country, we have unfortunately seen a year-on-year increase in infant mortality rates. What we are doing now is we're working together across the system with partners, so with the NHS, with GLA colleagues, with ADPH, in order to come together to develop a strategy around reducing infant deaths in London. And the reason why that is important is because in order to reduce infant deaths in London, we have to ensure that women and their families receive good maternal care and also receive good care pre-pregnancy. We need to tackle not only health inequalities around wider determinants, but also we need to look at how healthcare services are organised in order to ensure that all women are receiving appropriate maternity care, and that the care of pregnant women isn't compromised by service changes due to COVID-19. Thank you.
Maria, perhaps on the question that I raised there, could you answer that?
So I would noted down two questions that you raised. One was about whether we had raised this issue with the Mayor of London. We haven't to date, I have to say. We have raised it with NHS England and also the regional team for London, the NHS regional team, including the regional midwife, and we have written to individual London trusts, but we would be delighted to submit evidence to this inquiry and to put these concerns to the Mayor going forward. I think the other question you asked was what the situation is now. And what we see it in London at the moment is that there's still a huge amount of variance around the restrictions that are in place. So some trusts have gone back to allowing postnatal visiting 24/7, but there are some trusts that are only allowing visiting for 4 hours, which is still quite a restricted amount of time compared to pre-pandemic visiting. So still quite a postcode lottery in that. We also see a number of trusts that are still only allowing one birth partner in labour. And we know that a lot of women really value the support of a doula or another relative or friend. And we are urging trusts to look at that and whether that restriction is still proportionate. And also we see with the staffing shortages that we have in London and elsewhere at the moment, that a number of home birth services and out of hospital birth centres are being suspended. And sometimes that's not an official suspension. My colleague kindly phoned round the London Trust last night to see how possible it would be to get a home birth. And only one trust officially said that their home birth was suspended, but 5 further trusts out of the 15 said that they had very limited availability and were unlikely to be able to offer a home birth last night. So that choice is still very much not always available too. So, and some of that is for valid reasons, but we really want to be clear that this is a choice that should be available to all women. Some women only feel safe giving birth at home or out of hospital, and it's really important that those choices are available to women and birthing people.
Thanks, Maria. I think what's clear to me perhaps here, and it will come from this, is there's a real space where perhaps the Mayor, with the help of Tom and Joanne as Deputy Mayor for Children and Families, can use convening powers, not statutory, to have almost what is best in class, in service, and put that forward to London. Coming on to Suzanne, back to you if that's okay. A survey in 2021 has shown that 5 of 15 trusts in London were rated worse than expected during pregnancy. One was somewhat worse than expected, another was worse than expected, and for maternity care in hospital, 3 of 18 trusts were rated worse than expected, and an additional 3 were somewhat worse than expected. What's your understanding, and can you explain to the committee, of what could cause these responses?
Yes, thank you. And I guess you're talking about CQC reports, aren't you? I think the most recent independent assessment of maternity services was done by Donna Ockenden into the tragedy that happened in Shrewsbury with years of underinvestment and understaffing of a service in Shrewsbury and the resulting baby deaths. And Donna's report draws a really clear line between staffing levels and safety. But I think in the testimonies that we've heard today is that there's another very clear line, which is between staffing and the kind of kindness and compassion that every midwife would want to give. And so where we're seeing services that are falling short and are falling below the kind of quality standards, there's a link there to the fact that we went into the pandemic nationally 2,500 midwives short of what is needed. And that has got worse. And I said this earlier, there are 100 fewer midwives working in the NHS in London today than there were a year ago. And that means that all of those services are stretched. And it is every day trying to juggle, just trying to keep services going, leads to some of those decisions that Maria and others have talked about the withdrawal of services. So I feel sometimes like we're a bit of a stuck record on this, but when you try to chase back what it is that is impacting on the quality or lack of quality in maternity services, it will always come back to the fact that for the last 10 years, maternity services across the UK and in London have not had the funding and the attention that they deserve and they require, and that women deserve.
Do you have any figures on the funding?
No, not to hand, but I can certainly make sure that the committee gets that kind of data.
I'd really be interested in that, because obviously I've struggled to find a specific maternity figure. Obviously the NHS budget has gone up by 50 billion, excluding the COVID money in the last 10 years. So I'd really like to understand how that impacts on maternity services. So if you could, I think that'd be very helpful. I'd also like to understand, speaking about funding, the government have obviously put in £127 million this year. How is that going to be? £50 million is for staffing, which I think we're going to come on to in a couple of sections' time. But how do you think, aside from staffing, that money is best spent to have the best outcomes?
So new money into the maternity services is hugely welcome. And it will definitely start to make some impact. And there are some really fantastic initiatives going on. We were talking earlier, Tom was talking about stillbirth, and there's been a national drive for the last 10 years about reducing stillbirth rates. And we've been one of the organisations that's been instrumental in designing new training and development packages for obstetricians and midwives to both spot those early signs of the things that might lead to stillbirth, how to intervene, and that kind of rolling out those interventions, which are a lot of that is around multidisciplinary training, time to train and money to train, multidisciplinary working, being able to review cases, money for governance in trusts when we look at the ability to actually really understand what has gone on. And I think most importantly, changing some of the cultures in maternity units to a just and learning culture, so that when things have gone wrong, midwives and obstetricians and the wider team are facilitated to understand what's gone wrong and learn from it, rather than to become defensive and close ranks.
Thank you. Sorry, just conscious that Maria has a hand up virtually, wants to come in.
Thanks. If I could, just because while Susan's on a roll, and then come back to Maria, is that okay?
Yeah, go ahead.
Thank you. So I just wanted to come back, because I wanted to pick up on, you said earlier, you used the word kindness, and I thought that was so important. And I did want to share briefly, whilst we're sharing stories, that my wife was also pregnant during COVID and gave birth. And actually, yes, there was many issues with the COVID things that we've talked about. But she actually suffered PTSD as a result of her birth, and the fact that the midwife suggested that she was killing her baby during birth, and that was what was the traumatic experience, and put her into therapy after that, and was deeply distressing for our family. So that kindness point, it's just so simple, and I really wanted to pick up on that. That it's not always the money or the big training, but just that kindness. And I think other stories have showed that as well. And just a final thing before I go to Maria, I wanted to ask you was if there was anything positive. We've talked a lot about the negatives. Have there been anything positive we can take out from COVID services, perhaps virtual stuff, that is going to be useful going forward?
So I think firstly, I think kindness is hugely important, and there's never any excuse or justification for unkindness. I guess except to say that when people are working under huge stress and pressures, then kindness is sometimes one of the things that goes, and that's one of the other, really awful consequences of what working through the pandemic was like. And no woman should ever be made to feel responsible or put in a position where her role in what's going on in her care is put into question. And I'm really sorry to hear that. And was there anything good? I think we all spent a lot of time, particularly early on in the pandemic, trying to clutch at some good things. And I think partly that was to try and keep people going, because actually working through the pandemic was so awful for so many midwives, and many midwives who were going to retire stayed on during the pandemic to try and keep their colleagues going. So we were all looking, but I have to say it is a bit like clutching at straws. Midwifery and maternity care is very much a relationship-based care, and therefore moving antenatal, it was amazing that we could move antenatal care online, but I don't think that that's where we want to be for the future, because actually it is that relationship that builds up that is so important. So we were able to do some antenatal education online. Women in kind of peer support groups online were able to give each other a lot more support. But actually, when we look at most of maternity care, it's not like so many other areas of healthcare where telemedicine has come to the fore during pandemic, and you think that can continue. I think there's very little that I'd say in maternity that we'd say that was great, and we're going to carry on with it.
Thanks. And Maria, coming to you online, is there anything you wanted to add on any of that conversation before we move on?
Thank you. I just wanted to add, I'm really sorry to hear that was your wife's experience. That's really awful to hear. I would echo that we emphasise during our training that it can sometimes feel to healthcare professionals that there's nothing that they can do in this environment where resources are very stretched, and we try and emphasise that what they say is so important and has such a important impact on the person who's hearing that, and that words can be incredibly powerful. I would also just back up what Suzanne said about we need to care for the carers to make sure that people have that sort of energy and that resilience and that ability to continue to care in the way that they want to as well. The reason I had put out my hand was just to respond to the funding point, because I think you were asking for a figure about what was needed, and I just wanted to point to the Health and Social Care Committee's report last year, which recommended that the government should invest a further 200 to 350 million a year in maternity services in order to make them sustainable. The 127 million, most of that is over a sort of two-year period, and what we really need is a commitment to invest in maternity services up to the level that they need each year on an ongoing basis, in order to make sure that we have the staff we need to even start to make a start on the other things that are really important in maternity services. That is the foundation for everything, really. So that is a figure worth looking at and a report worth referring to.
Thanks, I think that's really helpful for reporting that. Tinuke, before we move on, was there anything you wanted to add on this section?
No, thank you.
Okay.
Thank you, Emma. So for the next section, we're going to talk about inequalities in maternal health and care. First, I'm going to turn to Marilena. Research has found that maternal mortality rates are more than 4 times higher for black women, 2 times higher for mixed ethnicity women, and almost twice as high for Asian women. What are the reasons for these disparities?
Thank you. I think the reasons for unpicking why ethnic inequalities in health exist is difficult. There is a complex interplay of deprivation, environmental, physiological, and health-related behaviours. And what we do know is that some of these risks, as I've already mentioned, impact on each other. So we know that people living in ethnic minority groups are disproportionately affected by socioeconomic deprivation. We also know that people in ethnic minority groups live with structural racism, and that can also reinforce the inequalities, for example, in housing and employment, which in turn can have a negative impact on health. And as we've already mentioned, COVID-19 has shone a light on the inequalities. And I think the role of this committee, which has been really great, has been to focus on that need to strengthen actions to prevent and manage ill health in deprived and ethnic minority communities. Tom's already mentioned some of the work that has been led by the Mayor of London, and in OHID we are working very closely not only with the GLA but also with the NHS and ADPH in order to ensure that we can help contribute to improving services and access. The other thing which hasn't come up is the importance of comprehensive good quality data in order for us to work with services to identify the specific needs of different groups. Much of the data which I have been able to present and others have been able to present has been national level data. And I think what we would like to do going forwards is advocate and try and get London level data for some of these disparities, because currently I can only give you some of the national figures, not the London figures. Thank you.
Thank you. And while I still have you talking, you mentioned earlier about the impact on people with a learning disability as well, who are also another group that are disproportionately impacted by services. Do you have anything further to add with that particular group? Can you shed a bit of light about some of your organisations and your views on services for people with learning disability?
I think with respect to maternity services, I probably can't, but I can give you a generalise about the impact on people with learning disabilities. We know that, for example, COVID significantly impacted on people with learning disabilities and their families. Overnight services were withdrawn. So overnight, people who were used to receiving care couldn't receive that care. We also know that that also impacted on families, because overnight the care which families had been receiving for their loved one was also withdrawn, and that also had a detrimental impact on the health and well-being of the carer as well as on the individual concerned. We know that nationally health outcomes are poorer for people with learning disabilities. So if you look at the LEADER studies, which is the inquiry into deaths of people with learning disabilities, we know that people with learning disabilities are more likely to die at a younger age than people without learning disabilities. I think there is a lot more that we can do to help support not just those people, but people with learning disabilities, but also their families. Thank you.
Thank you. I'm going to turn to Maria as well. So just thinking about London and our demographics, are we facing anything in particular in terms of challenges in relation to the inequalities that we've heard about? Can we draw comparisons, or what are the outcome differences in other, say, urban, ethnically diverse populations? Birmingham, Manchester come to mind in terms of other large cities in the UK. Is there anything unique to London that we aren't seeing in other similarly made up populations across the country?
Sorry, just finding my mute button. That's a very good question. I'm not sure that I'm best placed to answer it, but what I can kind of explain is what we found in the racial injustice inquiry that Birthrights facilitated and that was published about a month ago. And the focus of that inquiry was less on those kind of clinical outcomes, but more on people's experiences of care and how they experienced the maternity care, what they felt they came up against, how they felt they were treated. And we did do a deep dive into our data of that to compare London to the rest of the country. And we found actually that London very much kind of echoed what was found in the country as a whole in terms of the themes from the inquiry. So we looked at whether women and birthing people, black and brown women and birthing people in particular, felt ignored and disbelieved. And in London, 63% said yes, they did. And in the UK as a whole, it was 61%. We looked at whether black and brown women and birthing people felt safe in their maternity care. In London, 60% said no, and that was the same figure nationally as well. And we asked people if they felt that their race had an impact on their maternity care. And in London, 63% felt that it had, and that was 65% in the rest of the country.
Thank you. We're going to turn to Tinuke for the next question. Do you feel that London's maternity services are meeting the needs of the city's diverse population?
That's a good question.
That's fine.
Sorry, excuse me. That's a good question, actually. I'd a couple of things going into my mind at the moment. I would say, are they equipped? Certainly from doing our 5 times more training, we realised that a lot of health professionals don't actually know about the statistics, and I think that can actually play a huge part in some of the outcomes that we see. So if you have maternity staff who are not aware that black women have a 5 times more higher risk, or 4 to 5 times more higher risk, you can't necessarily take the steps to ensure that they are having better care or safer care for that matter. So if and I know this because there is currently no there's nothing about the statistics in the medical curriculum, so they're not actually officially being taught about this information, despite it being around for decades now. I can certainly talk about our survey and some of the findings there that maybe might be of interest to sort of answer, your question. We know that black women are not necessarily dying from anything more than what white women are dying for. If you look closely into the Embrace statistics, actually they're dying from the same things. They're just dying at a higher rate, and obviously they are overrepresented in that data because they only account for a really small number. So we know that, for every one woman that dies, there's about 100 more behind her that are suffering from morbidity, but this actually isn't captured anywhere. And we found that, a lot from our survey, we found a lot of black women just simply are not complaining because they're going through poorer experiences and not being believed in the first place. And then it makes it very difficult for them to now come and complain about the services. Another thing that we found that was quite interesting is a lot of people try to say that it's because of socio-economic status, and black people come from lower socio-economic status and live in poorer areas, and this is accounts for why there's this higher disparity. But what we've certainly found from our survey is that a lot of black women, more than half of the women that responded, were degree educated and more, and earned above the national average. So they also reported really poor outcomes. And for us, that sort of refutes that stereotype of, well, it's because you're poor and it's because you're black and this is why this is happening. So I think to answer the question, it's like someone mentioned before, there's a lot of different levels there, and you can't just point it down to like one thing. There's so many different layers. I hope I was able to answer your question.
Yeah, sure. Just while I still have you on the mic, I know Dr. Suzanne Tyler wants to come in on this, but I just want to just ask you, in terms of the Mayor of London, what actions do you feel he could take, or what actions would you like him to take?
Well, I would certainly say, making part of our recommendations is that people need to be trained about this. This should be anybody that's working within maternity services should indeed know about the statistics and the maternity outcomes for black people and those that come from ethnic minority backgrounds as well, and that health professionals actually need to be more aware of conditions that affect black people specifically. So, for example, in our report and in our survey, we heard that some health professionals didn't know what things like keloids look like on black skin. For example, a lady was saying that she was having a needle put into her, and she was saying, look, I have sickle cell, and sickle cell is obviously something that affects black people a lot more in the population, and it triggered a crisis. But she was trying to let her know that, please be a bit careful with me, a bit gentle with me, with the way you handle me. And unfortunately, the health professional didn't really know much about sickle cell and did something that triggered a crisis. So you can imagine, obviously, being in labour or having had the baby, being in pain, and then having a crisis on top of that. There doesn't seem to be a lot of information that, things that specifically affect black people, and that goes hand in hand with, making sure that they know about the statistics and things that is culturally sensitive, basically.
Thank you. And Dr. Suzanne Tyler, you wanted to come in, but if you could also draw in and answer the question about what actions you would like to see the Mayor take as well.
So what I wanted to come in to say was the other issue around inequalities that is very London specific is that there is a much greater proportion of the midwifery and maternity support worker workforce who are people of colour in London than we see in other parts of the United Kingdom. And what we see of the experience of black workers, midwives and MSWs, is that they are more likely to face not only discrimination and racism at work, but they are more likely to be disciplined. They get harsher outcomes when they go through employment processes, and they're less likely to get promoted. So the experience of the black community generally is experienced by our midwifery and MSW community. And I think that's somewhere where the Mayor has got a really strong advocacy role, because to deliver more inclusive maternity services for everyone requires us that work on stamping out racism and replacing it with an ethos of respect and dignity and compassion for everybody who works in the NHS. And just on what Tinuke was talking about how cultural sensitivity, I think one of the really good news stories is that there is a mounting pace now of acknowledgement and work to look at the way that our midwives and obstetricians are trained, particularly in the fact that everything in our textbooks, everything in our learning starts from that white is the normal. So one of the very basic things that happens when a newborn baby is born is the first observations to make sure it's healthy. One of those is how pink is it? and there is a kind of how pink is that baby, and so that work to actually think about the way that we even approach the very basics is starting now, and I think a lot of that is down to the voices of people like Tinuke and the work that Maria and others have done as well.
Thank you for that. I understand Assemblymember Duval needs to leave soon, so I think what I will do is just pause the questioning for now, because there's some formal bits of business that we do before the end of a committee, which I want to make sure that is completed before Len leaves. So can we delegate authority to me as chair in consultation with party group lead members to agree any outputs from the discussion? Agreed. And can we note our work programme? And also the date of the next meeting of the committee, which is scheduled for the 6th of October 2022 at 10 a.m. here in the chamber. And there's no urgent business that's been made aware to me. So I'll continue with the last round of questioning with our guests. I just want to confirm with the chair if there's anything else I need to before. Thank you. So sorry to interrupt, but we just needed to make sure that was done while we had members in the room. Lastly, in terms of the mayor's actions, is there anything that you want to add in terms of what can be taken?
Well, I think that the Mayor's action for me is really about that advocacy around stamping out racism in the NHS, as in all parts of society in London, because that will make things better for the black and brown midwives and MSWs who work there, and that will lead to things that are better for the women that use the service too.
Thank you. I'm going to turn to Assemblymember Best again for the final round of questioning.
Thanks, Chair. I was going to ask about whether there was a shortage and some figures, but we kind of addressed that earlier. But the question I had was the nursery and midwifery register tells a different story to the NHS data. One register says that we've had year-on-year increase. The NHS data says something different. Do you know why there's the contradiction between the two?
Yes, so every nurse and midwife has to be registered once they've qualified, whether or not you're working. So what we have is we have a register of everybody who has undertaken a nursing or a midwifery course and qualification and is on the register. That is different to how many people are actually working in the NHS. And there are two things on that staffing shortage. One is, do we have the right number of people to start with? And the other is, even given do we have the right number of people, do we have high vacancy rates? And in midwifery, it is that double whammy. So we don't have enough people to start with, and on top of that, we are seeing increasingly high vacancy rates. And so we have a double whammy of shortage.
Just wanted to comment at that point, just to make clear that it's an informal session now with Assemblymember Duval leaving. We can continue.
Thank you. So what do you think is in London, not in terms of percentage, in terms of actual vacancies, what do you think is the vacancy deficit or midwife deficit?
So what we do know is that the number of, we've got 2.5% fewer midwives working in London today than we had a year ago. So there are 100 fewer midwives actually employed today than there were a year ago in London. And the vacancy rates, I don't have to hand the vacancy rates by trusts for London. But again, I think that is data that I might be able to get for you, or certainly be able to find from NHS London.
Thank you. I think that would be something really important for the percentage is obviously good to know, but in terms of what we can do, it'd be good to know the actual number that we're looking for in London. What I wanted to speak about is partly because of obviously Brexit and leaving the EU. There's been a shift in the demographic of recruits. So in 2017 to 2018, there was 68,434 people from outside the EU and outside the UK applying, and it's now, or enrolled, employed, and now it's 113,579. So I think in terms of a positive light, we've talked a lot about cultural competency. So in that rise, or the importance of cultural competency and perhaps where it hasn't happened, what positive impact can that rise have on the NHS?
So I think we were extremely anxious before Brexit actually happened that what we would see would be a big reduction of our European born midwives leaving the UK. And I think that probably hasn't happened to quite the extent that we thought it was going to happen. And now one of the NHS England's key strategies for getting more nurses and midwives into the UK workforce is actually overseas recruitment. I think there's two things there. One is, I think there is an ethical argument to be had about the UK taking nurses and midwives from countries, often developing countries and poorer countries, that desperately need their nurses and midwives. So I think there is an ethical issue there that we should all consider. Midwifery is slightly different to nursing on that kind of data because there are very few countries in the world that have midwifery education and training and development where midwives do exactly what midwives here do. And what we don't want to do is import obstetric nurses who actually aren't able to work as midwives. So there has been a lot of talk at the moment about overseas recruitment of midwives, but I know from the heads of midwifery in London that the number of actual overseas recruits who are translating into people in their units is at the moment very, very small. So I think in nursing it might be slightly different, but in midwifery the scope for overseas development is actually quite small. And I would say that our biggest challenge is let's retain the midwives that we've got and the support workers that we've got. In our last survey, 54% said they were actively thinking of leaving. And that's because of all the things that we've talked about today, of those shortages, of toxic culture, of being burnt out and exhausted, of feeling undervalued. And so actually what we need is a working environment that keeps the midwives that we've got rather than tries to find new places to recruit them from.
Thanks. I certainly agree with you on the moral point. I think that's one of my main issues with the EU, to be honest, and why I was a leaver is because of the damage we were doing to other less wealthy countries in the EU. So I think that's a valid point that you made. But I did want to touch on the element of, obviously, we've got, a large proportion of our workforce is extremely culturally diverse, and that does bring positives. Do you recognise that? That's the point I'm trying to get to, because a lot of the evidence that you've brought up today at Tinuke, it shows how that cultural competency is needed, and surely this more diverse workforce that we're now benefiting from does bring that benefit.
So I think like all elements of society, and I think probably London is a richer culturally experience for all of us because of the diversity, because of the huge variety and range of people that we have, and that is equally true in maternity services, and that the diversity of cultures that we see in maternity services only enriches them. But what we have to make sure is all of those predominantly black and brown midwives and maternity support workers have agency, are empowered, and are actually able to contribute to making sure that the provision of care is also culturally diverse. And what we know is that the experience of working in the NHS, if you are a black and brown midwife, is not always an empowering and enriching experience. And so we're probably not getting the benefit that those people could bring.
Sorry, I just wanted to kind of touch on that point. Just reiterating that, we have conversations with a lot of different organisations, and it's always said, oh, well, if we get more black midwives, is that going to make a difference? And can I be quite frank? No, it's not going to make a difference if they're coming into the workforce and they're being taught the same things as the white midwives are, and then it's not actually culturally sensitive, and then again they're not being taught about the statistics and what is going on within the community of black people. Like I said, so many people attend our training on 5 times more and do not know this is happening right now here in the UK. They think it's something that's happening overseas in America, and it just exists over there and it's not here. So I think it's obviously it's important, of course. It's definitely important because we need representation at all different levels when it comes to staffing. But what they're learning is really important too. So I think it just goes back to, you know, the curriculum and what's in there, and you know how they can take that out into the profession when they qualify.
Thanks. I think that's a really important point to make as well. For the report, I'm just looking. I think the question on the safety is kind of been answered, and we've kind of also touched on the government funding and what that will do for workforces. But I mean, was there anything that you wanted to add on that, Suzanne, about how it could be best directed?
I think just the final thing to note on funding, because the funding is hugely welcome, and there was 95 million for additional maternity services and training places this year. But we've got more midwives leaving than we're putting in. So although we are training more midwives, actually for every midwife that we train as a whole person, we actually only end up with half a person's worth of addition at the end, because we're actually losing more than we're putting in. So for me, at the moment, retention is the key to making the improvements in maternity services that we all want to see.
Thanks. Again, I don't want to make you repeat yourself, because we've touched on this a lot throughout the session, but also it's important that we make it clear. So just a final question on what are the main challenges in delivering maternity services from the perspective of midwives and staff?
I think it is time to care. It is time to care, it's time to learn, it's time to reflect, it's time to be compassionate, it's time to decompress. So when I very first started working around midwives, what would very often happen is a midwife would be in a room with a labouring woman. The labour would finish. And the midwife would come out of that room, and she would have a pause where she would either think, oh my goodness, that went amazingly, fabulous. Or she'd have that time to think, do you know what, I really wish I could have done that differently. And she'd have time to pause. What happens now? She runs straight into the next room and gets on to looking after the next woman, and then the next woman, and then the next woman. And so the shortages we have in staff are being felt in all sorts of ways, from really big things to the really tiny things. And I think the lessons that I took so much from Tinuke's and 5 times more report, that we're looking at access, we're looking at experiences, and we're looking at outcomes. And you can't separate those things. And they are most stark for black and brown women, but actually all of those stories are also being experienced by white Londoners too.
Thank you. Finally, can I just come to you, Maria, on the video call, not forgetting that you're still here with us. There's 3,000 more midwives today than there was 10 years ago, but what is coming through is that's not meeting the demand. And so just still want to understand in terms of figures, what's the shortage, you know, because obviously we've got more midwives, but if it's not meeting population demand, what are we looking at that we need?
I don't have a figure in terms of what I think that's more Suzanne's kind of area of expertise. But I think we all recognise that there is this, you know, there's a shortage of midwives in the system. There's also a shortage of obstetricians, but also there's this really challenging environment where we're losing people faster than we can replace them, as Suzanne said. So, you know, in some ways, I think the figure is a kind of, you know, a sideshow. We need to sort of tackle the climate that we're in. We need to make maternity care an attractive place to work again, where people can deliver the care that they want to give. And that means, you know, looking at all things from flexible working patterns to pay to, you know, but it also means looking at the kind of models of care that people are working in. And you know, I think we know the kind of environment that staff want to work in. They want to be respected. They want to be able to give autonomous care. They want to work in teams where their role is respected and they can work with colleagues in a constructive way. And you know, continuity of care is a live issue at the moment. It was a really key plank of the maternity transformation programme. We know that it really improves outcomes for women and birthing people. We know that a lot of staff like to work in that model where it's resourced appropriately because they can have that relationship with the people they look after. But we're in this chicken and egg situation where trusts are saying that they can't continue to roll out that model of care because they haven't got enough staff. So, you know, it's a real kind of crux point at the moment where unless we do something to change things, we're not going to hang on to those people. We've got to give people hope that they can continue in this profession and give the care that they want to give. And that's going to make things better for both staff and for the women and birthing people that they're caring for.
Thanks, Maria. I think just hopefully what we'll bring out in our report is that number, because that's what, to me, I think would be really beneficial if we understand what that specific number is in London. You know, if there's an increase but it's not enough, you know, I just want to know what is the magic number, 10,000, 20,000, 50,000. So hopefully we can bring that out. But I just say, I don't know.
I think Dr. Tyler wants to come in actually on that question.
Sorry.
Yeah, I think you're right. It's the numbers that, you know, the numbers kind of depends where you're looking at things. But what is very clear is that the commitment the commitment to train more midwives was made about there was a commitment to train 3,500 more midwives, and that was a fantastic thing. But that has not resulted in 3,500 more midwives actually being in the workforce. And the latest data from the NHS is that in London there are 100 fewer midwives than there were a year ago. There are 500 fewer than there were than across the UK. And I think one of the other huge pressures on this is that some of the things we've talked about today about the amazing things that maternity services can do, like being involved in mental health services, is that we constantly add things into what we want midwives and the maternity services to do. We want them to do smoking cessation. Of course we do. We want them to do weight management. We want them to be alert to perinatal mental health. We add more and more jobs in, but we don't increase the amount of time there is to be able to care to women.
Thank you.
Thank you. I think I'd like to thank all of the guests for their contributions today. It's really important that we've chosen to look at this issue. I know it's important to Assembly members as well. We heard earlier from Assembly Member Best's personal experiences as well. I have to say I was one of those parents waiting in the car outside that couldn't join my wife during her scans. So it's something that I'm really interested to hear from other Londoners about as well. As I mentioned at the beginning of the meeting, we'll be reaching out to people all across London, and I'd really appreciate your support in getting through to those networks to make sure that we really recognise what London has experienced during the pandemic, but also see how we can improve services going forward. So with that, I will close the meeting.